what we,
And Pat was doing a lot of talking, and she does really well on there. It picks up her stuff pretty well.
Yeah.
I just have to cut about half of it out.
Boy, that's why I said I want other people than me to speak. But sometimes there's like this pregnant pause and I have to think about what to say to get it moving again.
Well, I think, like I say, I think Otter does a good job transcribing your voice. It's gotten used to you, I guess.
Ah, good.
Good. Oh yeah, much better. We can see your face.
Yes, thank you.
I see you turned the whole thing around. Thank you so much. Yeah. And I want to ask you to unmute whenever you can.
Yeah. There she
All
is.
right. Are you all going to show the slides, or do you want me to show the slides?
So we're trying to do two actual computers. The computer I am on is going to be the demonstration computer. We're trying to get Collin logged into one. If he can gain access into it, he will be able to manage the PowerPoint himself.
Okay.
Just give us a couple of minutes as we're trying to get into the internet.
So you'll have
Weather's not helping us.
two connections.
Yeah, the weather is not the best friend right now, the connections.
Gotcha. It sounds okay. It sounds good. And picture's good.
Mhm.
We'll see how long we can keep it up. We've had about every situation of weather and internet connectivity and solar storms and anything that, I mean, we've been tested on this Zoom
We have.
things over the last year and a half. So
I hope people start arriving soon. It's 10 till.
it's
Usually we have people talking. Anybody in the waiting room?
nope.
Uh-oh.
Is that nobody's coming? I don't think so. In fact, on that, the one I was watching a tape the other day, and it said people were worried it got to be 2 o'clock and nobody was there, and there was, and all of a sudden somebody said, "Is there anybody in the waiting room?" Is it 14 people are in the waiting room?
That's why I asked you.
Yeah.
Rodney, you were purple for a few minutes.
Yeah, I know that. I don't know what the deal is. I may have to send this computer back. Or it's a connection.
Judson,
I'm not sure
would
what
you
the,
be, Judson, would you be able to share me as the host so that I can share my screen?
Yes. In fact, I'm going to make you a co-host.
All right, thank you very much.
And then you'll have privileges.
I'll bring your chair over so-
check something here.
Band ready? Let's see, this works. Host disabled participant sharing, okay. Let's see.
Okay, Jamie, you should be co-host now.
All right, let me try it out again.
See if you have sharing.
I do have sharing privileges. Okay, here we go. Let's see if this works. Sure.
Oh yeah, Rodney's camera is tough. Good. We can see that
From the beginning, good?
in edit mode. There it is, presentation mode. Yeah, great. Here's Michael Foxworth.
Let's see. He answered the rating.
Can't see Collin. We got to see you.
Oh, offset because of our heights.
Yeah.
So we have how many participants?
Judd, do you want to put the agenda up or wait till 2 o'clock?
We can do that. I was waiting for them to test.
Okay.
And Jamie, can you advance? Okay. Yeah, there you go.
Want to make me co-host?
Is that Michael?
Well, some vision, yeah. Sort of
Yeah.
like.
Well, Colin, I see you're from Canada there, huh?
I am indeed. Yep.
Congratulations on your women's soccer team winning the gold medal there.
That's right. It was very exciting. Yeah.
That's when we were all gathered around watching.
Yeah.
Yeah. I made a little bit of a ruckus when the penalty shootout was going on, but it was very exciting.
Yeah.
So Jamie, if you feel
Join
like
the
you
meeting.
are ready, then we're going to put up a little title slide at first until the meeting starts, so the little agenda.
Make sure she's comfortable.
Yeah.
Well, I'm gonna try to change a little bit here real quick.
Hey, Pat.
Yeah, hi Bruce.
Hi, how you doing today?
Love your background.
Oh, I can't see it yet. Is that the sun coming up behind the earth or something?
Yes, uh-huh.
Oh, good. I like it too. Yeah.
We need you a little louder if you can turn your volume up.
No, I just have to change the position of my holder and get it closer. Okay. I just want, you got my note about my discussion with Sammy Gitan at the MIT group.
Yes.
And I told you, he just is working on,
Everybody in the background.
he's working on mechanisms to some kind of mechanical devices
I have no idea how to
to help us.
operate this.
Right.
But they're based on he's the secret stuff based, I think, on a sonogram test. But he won't be able to talk to us before next month or October.
Okay. Yeah, I had read that you said there was no update, so I wasn't adding you to the agenda.
Good.
Okay, thanks for that. I have to go one more second before we start. Hold on.
Mike Foxworth, are you there? No. Mike?
Yes, he's muted.
I'm here somewhere.
Oh, Mike?
Yeah.
Before we begin, or maybe I should wait till later, but I want to give a big shout out to Mike Foxworth for the fabulous video he put on that we can see how somebody's dedicated to virtual tennis can overcome PN if he really wants to do it. Yes, good work there, Mike. Did everybody see his video? If
Yeah, you
haven't
mean
seen it,
the tennis?
yeah,
Uh-huh.
that was pretty terrific, I thought.
Everybody ought to take a look at that.
Yes, I think so. That's a highlight. That should be on Michael Wright's success stories, and we should put it on our Facebook page and website.
I can show it sometime if you want.
Well, I've seen it. I think we have to spread it further than this group. Or maybe it's up to the presidents, but I mean, I'm just saying we should show it to the Facebook page, the website, and everybody.
I'm sorry, I had to get up for a moment. What are we showing on the website? Bruce?
I was recommending that we show Mike's video of him playing virtual tennis.
Oh, okay. I have
If you
no
haven't- if you
idea.
haven't- Mike, you better spread it around the core group first, so they know what I'm talking about. And then they'll watch the video. They'll agree with me. They
Right, I
should
have
go
no
everywhere.
idea.
Great success story.
Are you all set? PT? Okay,
Jamie and Collin, you okay?
it looks good.
Uh,
So we'll, it's 4 minutes till. We usually, you know, we have it scheduled for 2. We usually wait a couple of minutes later than that, just for the latecomers.
Right. Can you make this slide just the presentation, not the formatting bar? There we go.
Sorry. Yeah,
Takes up less space. I
Good.
can see I'm going to have trouble monitoring. So if people don't have their hands up, have their hands up, I may miss them. So I'll need help from people, Mike and Terry,
Okay,
please, if I'm missing somebody.
Join the meeting.
Good. 2 people. That sound makes me happy.
Oh,
Oh, good. There's
Time's up.
Joanne. Haven't seen Steve yet.
Oh, sorry.
Hi, Joanne.
Hi, Pat. How are you?
I'm good. Are you able to give a quick overview of the fall programs that are coming up, or would you prefer not to?
It would be very quick, but I can do it.
Yes, it's just during our wrap up. It's just to say in October we're having and in November we're having.
Sure. I've got to just remember everybody's
Okay.
name.
That's why I was turning to you and Steve, because I couldn't remember who was.
Yeah. Okay. Yeah. It's Joe Turpenning and
Yeah.
the other guy.
Okay.
It doesn't even matter if it's not true,
Oh, okay.
because
Well,
it's
that's
in the
easy.
future. Hey,
Okay. Nobody's going to remember, right?
Well, I hope they're making a note of the dates and the people.
Right.
big crowd.
Yeah, this is great. I'm happy. I think we didn't meet in July, so people are interested in reconnecting.
Right. I lost my watch. What time do you have, Pat?
2 o'clock on
Okay,
the nose.
all right.
Well, you can see my problem I have with my video. It says
Yeah.
it's on, but nothing's showing, just my name. So
I would take that back right away. Is that a new computer?
yeah,
Yeah. Well, if it doesn't work in the first 30 days, it's not going to work.
yeah,
That's my theory anyway.
yeah.
I can't keep up. There's Walt Carlson.
Yeah, this is great. We're up to 29.
Okay, Pat, it's your show. I can I can let people in while you're talking if you want to start or if you want to wait a little while.
I'll wait 2 minutes.
Okay.
I don't see Steve Klitzman yet. I'm looking for our regulars and new people as well. Hi, Terry. Hi, Rebecca.
I think you're muted.
Are you muting everyone, Judd?
No, I wasn't. But most people are just on mute right now.
Right. I'm going to say that we're going to mute during the presentation.
Good.
Jaime and Collin, just so you know, we're just going to do a quick welcome and then I'll be introducing you and you have the first hour.
Sounds good.
Perfect. That includes the Q&A session. Just so you can pace yourself.
Awesome. Yep. Thank you.
Okay, I think we are go. Judd, you agree?
Okay.
All right.
Yeah.
Hello, everyone, and welcome. I'm Pat Gualtieri, and I'm hosting, moderating this August meeting of the DCPN support group. Happy to have everyone joining us today, especially those of you who are new to the group. Program after our presentation to introduce yourself and perhaps tell us a little bit about your PN journey. We have a terrific agenda today. I'm really pleased to see so many people here with us. It's basically a threefold agenda. If you can show it, Judd. I'll go ahead and speak as he gets it up. There we go. We are going to have, first of all, a presentation by Collin Phillips and Jaime Cruz, both of whom are highly credentialed physical therapists who practice in the local area. I personally have a connection with them in full disclosure. I have been working with them for about 6 months, both before and after my back surgery. And I can't recommend them highly enough, which is why I asked them if they would address our group, because I think they have some answers that we are looking for and some suggestions that would be helpful. They will be addressing the role of the physical therapist in helping you maintain your overall fitness, but they're also going to address very specifically the whole question of balance, mobility, and fall prevention, which is a consequence of PN for most of us. They are helping me with specific exercises directed at strengthening my core, but also strengthening my abilities in terms of balance and fall prevention. So they will be talking to us in just a few moments. Then we are going to hear from Terry Orlando, one of our own members who had her personal story published on the Foundation for Peripheral Neuropathy website. We're very proud of her and pleased that she took the opportunity to explain her journey a little bit and the importance and impact of our group in traveling that journey. Then we'll hear from Rebecca on a treasurer's report of where we stand, followed by an introduction of new guests and open discussion for a period. And then we'll do the meeting wrap up of announcements and what's coming in the next few months. And with that said, I'm going to turn to Jaime and Collin. I again emphasize that they are board certified orthopedic specialists and both have their doctorate in physical therapy. Their full biographies and the presentation will be posted on our website And as I said, the contact information, in case you have further questions or would like to speak with them directly. With that said, Jaime and Collin, you're on.
Thank you so much, Pat, for that introduction. Can everybody hear us clearly?
Yes.
Good.
Awesome. As Pat introduced, I am Jaime Cruz. I am the clinic director and a treating physical therapist at the Falls Church location for PT Solutions.
And my name's Collin, as you see on the screen. I also work at the PT Solutions at Falls Church. I've been very fortunate to have developed a really nice relationship, as Pat has mentioned, and really honored to sort of have this opportunity to speak with you guys today. We're both board certified in orthopedic specialty. My brief history from Canada originally, came down to the United States. Went to school at Duquesne University in Pittsburgh. I graduated in 2017 and have been working in various outpatient settings since that time. I arrived in the area here in Northern Virginia about 2 years ago.
Yeah. And then
Oh, sorry. Okay, sorry. I messed up.
you're okay. As I was saying, I am the clinic director here at the Falls Church location. I am originally a native from the island of Guam. My background comes from 4 years at Columbia College, where I majored in biology and public health science. And then I went ahead and received my doctorate of physical therapy at Mary Baldwin University down in Stanton, Virginia. I relocated to the Northern Virginia area roughly around summer of 2018. So it's been really enjoyable being in this area.
Okay, so just briefly, sort of what the plan is for today with us. We're going to talk about, as Pat mentioned, normal aging for one, to talk about some of the changes that the body sort of undergoes as it relates to balance and strength and falls. And then we're going to take a little bit of a targeted approach as far as what happens with peripheral neuropathy, sort of what changes are accelerated, what new changes occur. And I'm sure there'll be lots that some of you can relate to in that capacity. We'll talk a little bit more specifically about falls and sort of the epidemic in a way of what falls can mean for people and quality of life, and ultimately sort of morbidity, what happens after a fall. And we're going to tie that into sort of what we do and the value that we provide as physical therapists, not only for balance and falls, but also specifically peripheral neuropathy and some of the complications that come as a result of that. We'll go over briefly a couple of exercise examples, nothing comprehensive. One thing that will be a theme today is that peripheral neuropathy can be very patient specific. And while general exercise and fitness is important, oftentimes there are more specific sort of individualized considerations that have to be made. So we're going to go over some sort of simple exercises that would probably benefit most. And then we'll talk about how physical therapy can kind of go above that, like Pat's alluded to earlier. And then we want to leave a good little bit of time afterwards for any questions that you might have related to the PowerPoint or any of the topics that maybe we didn't quite get to touch upon. Okay.
Thank you, Collin. Could I just stop you for a moment, because there is a box blocking your slides.
Okay.
And it says, please move this window away, and you are in control of that. And Judd, if you could please mute everyone other than our speakers so that we don't have the background noise.
Okay. Trying to figure this out.
So yeah, that looks like I'm not able to click and drag it at all or anything. Let me see if I can stop sharing for a moment. Let's see if we can do this again.
That's a new one.
Yeah. I've seen a lot of like error messages, and that's a new one. How are we looking now?
Good.
Great. Okay. We figured it out. We gotten too far away from technology. Okay, so normal changes with aging. So as I mentioned, changes do occur as we age naturally. So what we see is as individuals get older, a lot of changes occur in the ability for the human body to take in information from the environment. And then some sort of pathological conditions or diseases, some of these processes can alter this ability or accelerate it. So as we get older, things change, visual system. So we lose our ability to see things clearly. We lose some light distinction. So our ability to differentiate light from dark changes. In the auditory system, so your hearing, obviously hearing can be lost, olfactory, smell, taste. So all these different body systems, it's sort of normal for us to lose them in some capacity as we age. Now, as you mentioned, some disease processes can accelerate or really impact this. So we're coming from a standpoint where as just people get older, there are a lot of systems that can be worked on and that can be improved just because of the normal sort of changes that happen with aging. Now, peripheral neuropathy, what happens is more specifically, we see changes in some of the systems that involve the peripheral nervous system, right? So in the physical therapy sort of realm, we see impact as it relates to motor neurons. So these are the muscles that, or the nerves that control your muscles. The sensory neurons, right? Those nerves that transmit information from your body to your brain to learn things about the environment. And then your autonomic neurons. So these are the neurons that relate to the visceral, the structures, your organs, help to control some of the more systemic things. So when peripheral neuropathy impacts motor neurons, Jaime, what would you say is what you see the most as it impacts the motor function?
Yeah, so when we're looking at how peripheral neuropathy affects the motor neurons, we see individuals with changes in their gait mechanics and how they're walking, a little bit of aspects of limping or even discomfort in that self due to the weakness in the motors, especially in the lower extremities. You would start to feel, if anything, like nighttime cramping or that restless leg syndrome that a lot of people are familiar with when it comes to those motor neurons itself. So
we also have on there atrophy. So atrophy is muscle wasting or shrinking in size. That can be from disuse, but it can also be from just the motor neuron not having the same ability to contract the muscle. So what we see is weakness, just not as strong in those muscles, those cramping, some of the twitching, and then the muscles actually changing in size. The sensory neurons, here's where we get numbness, tingling, that feeling of fuzziness, not exactly knowing where your feet are in space, or your hands, or some of the other body parts, depending on the kind of specific distribution of your peripheral neuropathy. But also things like discrimination. So if you're holding an object, not quite being able to discern exactly what it is, or if you're standing on a surface, not exactly being able to tell, what am I standing on? And, grass might feel the same as a flat floor, which might feel the same as a nail stuck in your foot. Now talking about wounds and the potential for injuries like that. And then autonomically, right, we see blood pressure issues. Systemically, we can see sort of chronic inflammation as it relates to the body's ability to control some inflammatory cells that the body has to deal with. And then sort of in the extremities, some of this vasodilation and vasoconstriction. So the blood vessels actually either shrinking or enlarging, which can cause all kinds of issues with temperature. So some people have really cold hands, cold feet. Some people can have really sort of up and down variations in the temperature of their extremities. And this can be not only uncomfortable, but it can cause and sort of accelerate some of these blood pressure changes that do occur. So that is sort of how peripheral neuropathy can accelerate some, again, those normal aging changes and really put the human body in a situation where not only is it in danger as it relates to the environment because you can't feel things and because you're weak, but also provides opportunity for improvement as physical therapy is a testament to. So just highlighting there, so physical therapy, we can impact all three of those sort of aspects of neurons. So working motor is probably what you most think of as it relates to physical therapy. We're going to work on strengthening the muscles. We're going to work on stretching to help with cramping. And as the muscles get stronger, that atrophy sort of tends to reverse the sensory. We can do a lot of work on working on sensory discrimination. I know something we do a lot of here is having people on different surfaces to be able to retrain the brain as it relates to, what are you feeling? What sort of messages are being sent to the brain here? Are we able to sort of discriminate between some of those different sensations? Sometimes it's putting someone on a foam pad, sometimes it's putting someone on a towel, or the artificial turf that we have in here, just to really give the brain different input to have to make some sort of discrimination. And then aerobically in here, this is something that I know Jamie's all about in here, is how physical therapy can affect the autonomic system.
Yeah, and potentially Pat can be a testament to it within her sessions here on that behalf is the autonomic nervous system. We as physical therapists have a really strong ability to really tap into the sweating, of course, vasodilation, constriction, and blood pressure changes. So a common thing that we always want to look at, which some people don't recognize, is we want to know your blood pressure, your heart rate, and how your body is responding to the therapeutic interventions we do provide you. Because with all of that autonomic changes, we can also improve more of, again, the following previous ones, the motor and the sensory neurons. I'm not sure how many times Pat can count on her hand where she was asking for a towel. So that's something we love to do here, just getting people aerobically trained, because everybody in their life wants to be out doing something active as much as possible.
And another point, something that hasn't really been mentioned yet, but pain. I mean, pain is an issue that so many people with peripheral neuropathy deal with. And some of the autonomic nervous system changes that occur have to do with pain control and chronic pain. And so what we see is that as soon as we start to test this autonomic system and get some of this kind of the body's response to aerobic exercise, is that we get a really nice hormonal response. So the body releases a lot of these good hormones that can help with pain control at the local level, so wherever the sort of the painful site is, but also it impacts the spinal cord, impacts the brain, and it can have a sort of a total descending effect on the body as it relates to pain relief. So it's why aerobic training or some of these more specific interventions that target the body's whole system can have a really helpful impact on chronic pain.
I'm sorry, again, I'm going to stop you for a moment, Jamie and Collin. We're having problems with background noise. I had asked everyone to make sure that they mute so that we don't hear that background. I think Jamie and Collin are in an empty studio, so I don't think the background noise is coming from them. But it's a shame because some valuable information may be being lost. So please keep your mics muted, and we appreciate that. Go ahead, please.
Thank you. Okay, so balance and falls. Here we go. So some quick kind of facts about falls. It's a big issue. So 20 to 30% of people over the age of 65 in the United States will have a fall every year. This isn't even people with balance issues. This is your healthiest of healthy to sort of the most impaired. You take that whole group of everyone over the age of 65, and 20 to 30% of them are going to have a fall every year. Now what we can look at as well is for people who, elderly people who are fracturing bones, how are they fracturing bones? 87% of them it's because of a fall. So there's only 13% of fractures occur by some other means. So falls are leading to a huge proportion of the fractures that some of the older people in the United States are suffering. As it relates specifically to the hip, which is probably the most dangerous and most destructive of fractures. We're seeing almost 200,000 hip fractures a year from falls. Now, of those who sustain the hip fractures, this is where it gets pretty scary, right? We're seeing death. People die immediately after a hip fracture. It's a huge impact on function. It's a huge impact on the system. Even if they don't pass away right away, within the next 6 months, that number is going to be doubling. And then if someone's fortunate enough to recover, there's a really good chance that they're going to be going to a long-term care facility. Now, this is not meant to scare you or terrify you in any way, but this is the magnitude of what we're dealing with as it relates to falls, and it's a reason why it's so important for physical therapists on our end. It's our sort of duty and responsibility to be screening for balance issues and falls. And if anything is present that we notice, whether it's strength deficits or balance issues, sensory issues, we need to be intervening. It's a big sort of ask on our end, and it's a challenge that any physical therapist should be up to meeting because of the possibilities of what happens after a fall. So that's again just to kind of show you the importance on our end. And if it didn't sort of register to you what can happen after a fall, here's some statistics that you can reference in the future.
And then going on to the non-physical effects on what can occur with falls itself, is the fear that comes after it. Someone experiences a fall, or they hear from a family or a friend that there was a fall. Fear becomes that first ongoing aspect. And then the fear itself limits an individual's participation with activities, whether it's activities at home that require. There we go, returning back to it. But the participation in fear of going outside, doing activities with other individuals that may be in different scenarios of different grass, one moment, I had a little technical difficulties here again. But then with that being said, having that fear and that limit going outside, that turns into more of that isolation category where people are staying home, not being as active, not getting engaged, which then that again affects their limit of activity, which can lead to the secondary aspects of debility, which can perpetuate the increased fall risk. So this cycle continues on just with the non-physical effects, and something that can be intervened immediately. Even if you saw a physical therapist, we can work into ways to help reduce that fear and increase your confidence in yourself. So you're not being limited going outside, you don't feel isolated, and you increase that limit of activity.
Great. Okay, so shifting quickly to balance, what goes on with balance? So in general, we think of there being really 3 systems, but we've broken one of the systems up into 2 separate ones. So we have your musculoskeletal system. So this is your muscles, your joints, your tendons. How are they responding to changes in your center of gravity? Neuromuscular. So in order for those muscles to work, your brain has to tell them to do something. So here we see, how does the brain take in information from the environment for one, but 2, how does the brain then tell the muscles, the joints, etc., to move? So that's an important part of balance. Third one is a visual system. So your eyes taking in information. How are you oriented relative to the ground? And then your vestibular system, or your inner ear system, that also gives your brain information about where you are relative to gravity, really. So what we see is that these 4 systems come together and provide the brain with an idea of where you are, where your environment is. Are you moving? Are you stationary? So any impact on any of those systems will result in a reduction in balance and an increase in falls. I'm going to try to move this box again here real quick. Okay, so as far as physical therapy, what we're really working on are these first two. Now we can work on vestibular impairments. Getting into that would be a whole sort of separate conversation. But as it relates to peripheral neuropathy and balance and falls, the musculoskeletal and the neuromuscular system are really what we're targeting when we're doing balance training in the clinic. Okay, so now let's talk about just sort of generalized strategies. Most important thing you can do is stay active. So regular exercise. People sometimes think about exercise as having to be this really intense, involved, structured protocol. You picture someone going to the gym and lifting all this weight over your head. And exercise can be pretty simple. For some people, taxing the body, taxing the muscles, taxing the joints can be as simple as going for a walk, twice daily walk, performing some simple exercises like some of the ones that we're going to talk about here. And for a lot of people, that is lots, and that's plenty to not only improve, but certainly maintain some of the mobility, the strength, and the balance that you might have. So other strategies to minimize the risk of falls. How is your environment? How is your house set up? Do you have clutter around the ground? What we see is that if someone is fortunate enough to have someone come to the house and do like a home assessment, which is something that physical therapists can do, occupational therapists as well, it's really a sort of a house assessment. Is there a lot of clutter? Are there fall risks as it relates to maybe throw rugs or poor kind of color differences on the ground whenever there's a change in elevation? How open are the pathways? How is your lighting in your house? So these are some of the strategies that physical therapists should at the very least have a conversation with you about if they're not able to come into the house and do an assessment. The other strategy that we do a lot in here is talking about assistive devices. So what do we typically see in here, would you say, Jamie?
I would say for assistive devices, we have individuals that would use things like a rollator that has a kind of like a front wheel walker that has a chair on it in order for them to sit down when they start to feel their legs become weak. Canes, and then as you know, there's different variation of canes in itself. So assistive devices, although some people can find that to be a debilitating aspect or a negative effect to utilize, there is a lot of benefits in using an assistive device, even if it means temporarily utilizing it while your body is rehabbing and getting stronger. And not thinking of it as a crutch, but an aid in itself.
And that's a good point. Some people have the thought that once they start using a walker, once they start using a cane, that's it. They're stuck with it forever. But it can be a helpful sort of aid, something to bridge the gap between where you are now and where you want to be, and allow you to be able to do what you want to do more safely. And again, when we talk about what happens when people fall, thinking about using an assistive device sometimes can become an easier decision when you think of it that way and you frame it as, this is something that's going to help me get to where I want to be. It's going to help me be safer. It's going to help me avoid this awful sequela that could happen should I have a fall. Okay, so physical therapy in a nutshell for peripheral neuropathy. So we've already talked about a lot of these things, but what we're looking at is how can we, for one, improve the systems that you do have, and then two, how can we compensate if we're not quite able to get the changes exactly how we want them to be. So sensory integration, that's what we talked about, using different surfaces, education on sensation loss and fall risk. Talking about wound care, wound checks on your feet. So especially in the case of diabetic peripheral neuropathy, checking the feet, making sure that the hygiene of the feet stays at its best to avoid wounds. That's a very important part of a physical therapy conversation. Instruction on home modifications, we just talked about, use of assistive devices. And then something that actually Pat and I talked about not too long ago is really working with a patient on, okay, yeah, we're doing all this great work on fall avoidance, but what happens when you do fall? Because we do see that, it's not a matter of completely eliminating falls from happening, but what we might be doing is taking someone who's falling once a week and getting them to the point where they only have to fall once or twice a year under some sort of circumstances. So in the event of a fall, how do you fall safely? What are you trying to do with your body as you're falling? What sort of strategies are you employing to reduce the risk of injury? And then once you're on the ground, how are you going to get back up? That's a big issue. It's not something that's easily talked about or conveyed in general over a Zoom call, because it's so individualized to the person, right? It depends on what's your environment like, what's your body shape, how heavy are you, how easily are you able to pull yourself up or push yourself up? Do you have someone else at home that can help you? Lots of different factors that go into what I like to think of as sort of strategizing. It's sort of a contingency plan. If I do fall, what am I going to do? So that's a conversation that you should be able to have with your physical therapist and really provide you with confidence, or at least a plan in the event that you do have a fall. And then our favorite part, exercising, right? This is the meat and bones of what we do. The strengthening, the mobility, the balance training. And again, it's not Olympic lifts. It's not taking a barbell and throwing it over your head 1,000 times. Strengthening, mobility, balance training is different for everybody depending on the level that you're at. And I think that's really part of the big value of physical therapy, is that physical therapists are experts at knowing what's appropriate for you, what's too easy, what's too hard, what's just right, and then doing so safely. So we take a lot of pride in our ability to prescribe not only exercise that's going to be helpful, but it's going to be at the right level for you.
Pat, it's Rebecca. I'm sorry. I've scrolled down through this. It looks like David Bush is the one that's not muted. Can you ask him to mute, please? Or can you do it for him? Because it's extremely distracting.
We have already muted David, and I think what we're finding is it's actually Jaime and Collin's channel.
We do have a little bit. We're not sure how loud it is, but
There's an echo.
if during the question part you want us to repeat anything, please let us know.
There's an echo of everything you say. There's a delayed 1 second echo. We're hearing it in the background again.
Okay.
Are both of your laptops open?
We only have one laptop right now.
Okay.
So
we can't fix it. We're going to go ahead, and I apologize. But as they said, they're willing to repeat, especially during the Q&A section.
Absolutely. We're trying to do our best here with the Zoom setup that we have.
Okay.
Okay. So now specifically looking at, what does the research say? We don't want to get too much into the research, but there was a study recently that looked at this 2-month protocol of it's a once weekly sort of home-based strength and balance training, and how that impacted. What the study looked at was different assessments related to functional mobility. How quickly can you stand up and walk 10 meters? How many times can you stand up and sit down from a chair? And then various assessments of strength, balance, range of motion, and then balance confidence. And what did they see, Jaime?
So looking at this article, which pretty much came out within the last 2 years itself, we saw significant improvements in the timed up and go, a 5-time sit to stand, ankle muscle strength, so all the muscles that go into your lower leg to the ankle itself, knee range of motion, and then balance confidence score, which is honestly the most important aspect there. Now, these tests, if you've been through physical therapy, you may not know the names of it, but a physical therapist hopefully has performed these tests on you specifically. Now, with the timed up and go, just a little background of it, it's measuring the distance or the time it takes you to do a certain amount of distance, and kind of correlates it into how safe you are, what your fall risk is. Same with the 5-time sit to stand, where as it is, you're standing up and sitting down about 5 times. And then we again are going to be timing how fast, how efficient that is, and using that with a standardized score to rate where you would land within your appropriate age group and gender.
Yeah, so basically what happened with the study was great. They took a bunch of individuals with peripheral neuropathy. They gave them this protocol that was just 2 months. And in just 2 months of once weekly exercising, we see improvements in a bunch of different measures as it relates to strength, balance, range of motion, confidence with gait. So sort of driving home the point that this doesn't have to be an intensive, laborious thing. This is something that you can do independently, obviously once you've been instructed and sort of advised by your physical therapist or whoever is prescribing this routine. You can see these improvements in as little as 2 months. Now, they also did longer term follow-up as well, which showed even further change, but it doesn't take long for you to start to notice improvements. Okay, so how do you get started? So just kind of quickly looking at the Foundation for Peripheral Neuropathy, they have a really nice sort of website with some resources on some simple exercises, pictures, etc. What we would say is that if you feel like you can do these exercises safely, really good place to start. You can look at some of the exercises that we're going to demonstrate here, but also that can be a nice resource for you as well. If you have any concern for falls or any other sort of safety concerns, then it's really recommended that you kind of seek the services of a licensed PT. Again, they can advise you, is this appropriate for you as far as where you are right now? They can make sure you're doing things properly with good form and that you're safe doing it. So that's a way of us saying, if you're confident with yourself and you're not someone who falls a lot, go ahead and get started on something. But if there's any concern or any hesitation, then PT can be a really nice resource for you to get started.
All right, so let's go into this little window here.
Yeah, so that's okay. So and there's just some other reasons. Again, you're going to get evaluated by a physical therapist. They're going to look at your strength. They're going to look at your balance, your range of motion. They're going to give you an individualized sort of home exercise program and things to do in the clinic, so that you know that what you're doing is appropriate and safe. Okay, so some exercise examples. We're going to go over these fairly quickly. Again, they should be pretty standard. And going with the safety theme here, whenever you are doing balance or kind of standing exercises, you want to put yourself in a position in your house where you're able to have support if you need. So if you have a corner of a counter that you can sort of have available to you, if you can put yourself in the corner of a room where you have walls, having a chair behind you, etc., really using your environment to, if you do have a unstable moment, you're not falling all the way to the ground. Okay, so the sitting toe raise. Let's go ahead and take a look at what this looks like. Sitting. So with a sitting toe raise here, what we're doing is we're working on the front of the ankle muscles. What Jamie's doing is that she's raising her toes up off the ground. She's holding for a couple seconds and then back down. What you'll probably find is as you start to do these, the legs will feel fatigued very quickly. You might feel some burning in the front of your legs, which is totally okay. That's just the muscles being used. Again, looking for height.
The exercise.
How high are those toes getting up off the ground? And then going to fatigue. So that's a nice rule of thumb with most of these exercises is, can you get to the point where those muscles are really fatigued? That's a good place to stop and take a little bit of a break. You're welcome to do multiple sets of these exercises. So you can do maybe a set of these ankle toe raises and then moving on to a different exercise and then returning back to them. You really have a lot of freedom in how you structure these exercises. So that's the sitting toe raise. The next one Jamie's going to show is the sit to stand. So this is, again, something that we use as an assessment, but also it's a really, really nice exercise, really functional. We have to get up out of chairs, off of surfaces all the time throughout the day. So practicing that can be a nice way to build strength that you know is going to translate to your daily life. So Jamie is crossing her arms over her chest and is standing up all the way tall. By putting the arms across the chest, you're not using them to push up out of the chair, so it's going to just make the muscles of the legs have to work that much harder. What Jamie's doing right now is pretty kind of straightforward. It's chair height. You can make it more challenging by using a lower surface or by using a surface that's a little bit sort of giving. Think of like a couch. It's a little bit harder to get off of a couch than it is to get off a nice hard chair, as I'm sure some of you have experienced. So what Jamie is going to do again with this exercise is just do as many as she can until she gets tired and then take a little bit of a break.
We can't see those exercises except in the small little window.
Oh yeah, let's go ahead and that's a good idea. How's that?
There we go.
Okay, good.
First one again.
Yeah, so the first one, for those if we didn't see, she's raising the toes up off the ground. The muscles in the front of the legs are the ones that we're targeting with that exercise. And looking at the height of the toes, how far can they get up off the ground? The second one was the sit to stand. So she's standing up nice and tall and then controlling the way back down to the chair. Now, Jamie made a good point. There will be many people where that is too challenging. So there are modifications. We talked about how to make it harder, but a way to make it easier is by using the hands. So she can use her hands to push herself up and then going back down without the hands. So what we call it is an eccentric exercise where she's controlling the lowering part of the movement, but she's using her hands to help herself up.
Collin, excuse me, if
Yes.
everyone turns their view to speaker view, you will get full screen and we'll see Jaime even better.
Yeah.
So if go from gallery to speaker view and you'll be able to see it. Thank you.
Sure thing. Also using a higher surface. So if you have a chair that's higher, that would be a way to make it easier. And then working down to lower and lower surfaces as it gets easier for you. I would say, and I think Jaime would agree, that if you're going to pick one exercise to sort of work on and focus on, it would be this one. This is really, really good exercise. It translates, again, really well to function and what you might have to do in your day-to-day. Okay, so next one will be standing marching. So here's where we want to put ourselves somewhere in the house where there's a surface that you can put your hands on to help balance. Back of the chair works really well. Again, a counter works well, or putting yourself in the corner of a room where you have walls to touch if you need. So what Jamie's doing here is she's raising her knees up. She's trying to get to the point where her thighs are horizontal. And she's alternating legs. Now, having the hands on the chair is a great place to start. It really lets you focus on the muscles of the legs and letting those get fatigued. However, to make this more of a balance exercise, what she can do is she can take one hand away. So now there's less sort of assistance from the upper extremities. So now her legs are going to have to work a little bit harder to make sure that she stays vertical and stays balanced. As that gets easy, Jaime can sort of do the final step, which is taking the hands actually all the way off of the chair. So now she's on one leg, right? It's basically a single leg balance as she's alternating legs. Now we can take that same progression and apply it to the next exercise, which is just standing knee flexion. So what she's doing is pulling that heel back towards her butt. Her knee is not going forward like it was in the last exercise, right? So it's not coming forward like that. What she's doing, she's pulling back and her knee is kind of staying in the same place. This one you'll feel in the back of the leg. Jamie's showing that kind of starting point there where both hands are on the chair, but like last time, it can be alternated to a single arm and then eventually to no hands. Okay, so next one is standing hip abduction. Just gonna turn perfectly so we see this one. So still there at the chair. What Jamie's gonna do is you're gonna kick a leg out to the side and then come back down. Now, it's not super easy to see from this angle, but what Jamie's not doing is leaning forward, and she's not leaning to the side like that. So you can see her upper body is staying pretty vertical, and it's just the leg that's coming out to the side. So Jamie's kicking out with her right leg right now, which means her left leg is taking a lot of weight. It's working on balance, and the right hip should be getting fatigued as she keeps kicking it out to the side. Again, we can apply that same principle from the previous exercise. If she wants to go to one hand to make it more challenging, she can do that. And if she wants to take both hands off of the chair, that is the most challenging. Okay, so quickly here. Okay, we'll go into the standing heel raise. So this is kind of the opposite of the first one. So the first one, those toes were coming up off of the ground and the heels were staying on the ground. This one, she's coming up onto her toes and those heels are coming high up off the ground. If I had to pick a second exercise that gives you a lot of benefit, if you're someone with balance deficits as it relates to peripheral neuropathy, this would be it. So this is working the calf muscles. So those muscles in the back of her leg, just above her ankle. Right now, she's putting both feet are bearing the same amount of weight, so about 50%. And she's coming up on those toes and then slowly lowering back down to the ground. That's another theme that you'll hear a lot with some of these exercises, that lowering portion of the motion should be nice and slow and controlled. So when you're standing up and sitting down, you're not flopping back into the chair. And here on this exercise, you're not slamming those heels back down onto the ground like that. Your PT would yell at you if you did that in the clinic. Here's a progression. So what Jamie's just done there is she's come up with both feet. She's taken one foot off the ground and then she lowers herself back down with the other. Might be a little hard to see with the angle, but again, she's coming up with both feet. That right foot is off the ground and she's lowering back down with the left. And she's doing that to, again, increase the sort of the load or the demand on the one leg. So this is a really, really nice progression that we like to use when those double leg heel raises get too easy. Now, the third and sort of final progression of that exercise is just to do the whole thing with one leg. So a single leg heel raise. This is very challenging. This is something that, you could take a 15, 16-year-old kid athlete, bring them in here and have them do a bunch of these, and they're going to get pretty fatigued. So this is a really, really good goal to work towards for just about anybody. What we use is a sort of a guide of 20 repetitions as a goal to be able to do in a row to say that you have strong calf muscles. So if you're looking for a benchmark or something to get to, being able to do 20 single leg heel raises is a really, really, really good benchmark to aim for. Now, again, you'll probably have to start with those double leg heel raises, maybe progress to the ones where you're going up with 2 and down with 1, and then eventually getting to the point where you can do a single leg heel raise on your own. Sure, let's see.
And then I would like to just put a little bit of a snippet with these exercises that you just got to witness. The reason why kind of Collin and I prioritize the sit to stand and the calf raises over the rest is because of the functional carry. As Collin mentioned, getting up from surfaces, whether it's your couch, the toilet, just a normal chair, the sit to stands can help maintain that functional independence. And in regards to those calf raises, those heel raises, that's great for trying to get into your car, going up and down your steps, negotiating in the environment where you have to do curves and you have that push off one leg in order to successfully negotiate an obstacle. So that's kind of why we also really find value in those two specific exercises.
Okay, now if you give us 1 second here. Okay, so we've just escaped to a different part. Hopefully this will help with some of the background noise that was going on because there was something else going on the other side of the clinic. So we're happy to answer any questions or clarify anything that might not have been heard earlier. Again, we apologize for the environment and the connectivity issues, but whatever time we have left over, Pat, happy to answer questions. You're welcome to ask out loud. You're welcome to type them into the chat. We have the chat open, so.
And we see Mr. Bruce already with his hand raised. So let's start off with Mr. Bruce.
Thank you, Jamie and Collin, for a very nice presentation. Very important what you said for all of us. My comment was, under adaptive devices, you kind of just went through use a cane and a walker to balance yourself and avoid falls. But if you're going to stay at home, well, anywhere you go to live, I'm living in my own home. We've adapted, or to accommodate my problems, a number of other devices that you should consider. For example, we have 2 floors. I have to go upstairs to sleep and downstairs to live. So we purchased these stair lift machines that will basically take you up a track from one floor to the other or down. So that's one thing, and that's on our support group website under devices. That's a mechanism you can use to make yourself when you can't walk the steps, they're
Mhm.
very helpful. The other thing I would recommend highly is lots and lots of grab bars. I have about 8 in each of my 2 bathrooms. Well, I have about 8 in the bathroom upstairs and a couple downstairs. And boy, they make it easier to transfer from the wheelchair or to the shower chair. In the shower, I have a rolling shower. There's 4 grab bars in there, which I use just to hold on to move around easier. So those are just a couple of further suggestions on adaptive
Yeah,
devices.
that's great, Bruce. Thank you for that. We did mention just specifically the cane and the walker, but there are a lot of assistive devices and adaptive devices, like you mentioned, that are great for in the home, but also for function. So we need to talk about braces, the use of AFOs or BKFOs, some of these other things that can help to compensate for strength loss. So good. I see down in the chat, can muscle loss be reversed? I've lost quite a bit in my ankles. Yeah, absolutely. Again, part of the reason that the muscles get weak can be atrophy, so actual shrinking in the size, but also your brain's ability to contract them. So regardless of the reason for the weakness, exercising and strengthening the muscles are almost guaranteed to bring strength back. Now, how much strength can be brought back? It depends on sort of the pathogenesis of the peripheral neuropathy, the chronicity, that kind of stuff. All things that your physical therapist would be able to talk to you about as it relates to prognosis. But long way of saying absolutely.
Yeah, and then I see Terry has 2 questions here about the red light and TENS unit, as well as nerve flossing in itself. So we do utilize TENS occasionally. There are some secondary individuals that we can help refer out. In physical therapy within our setting here specifically, I can speak that we try to utilize your time in this clinic to work into the exercise aspect, since a lot of the TENS units can now be prescribed through insurance and you can get it over for home in itself. But we do utilize it. We do work with education on how to properly use the TENS unit, because that's something that not many people go over. And then with regards to the nerve flossing exercises, that too we do utilize as needed and based on each individual. There are some benefits with using nerve flossing. Again, if done incorrectly, you actually can give a quick stretch to those nerves, and that might be a little bit more harmful than good. So that's all with case by case.
Okay. Let's have some rules here, because we have a lot of questions. The best way to do it is to put it in the chat, and we will call on you or explain, indicate who is next. We've already had several questions. What is nerve flossing? If you could explain that, Jaime, please, because I don't think it's a familiar term. And then we'll go to Diana.
All right, so
Can I just,
After nerve flossing.
I want to,
All
I go to a physical therapist. You guys are on Route 50, right?
yes, ma'am.
I go to Advantage across the street, and they've done some nerve flossing with me. And then usually at the end of my sessions, they've done the TENS unit, like the buzzing on my feet. So I was just wondering if you guys had a similar setup, or what was going on there. And they usually
still need to understand what nerve flossing is.
Go ahead.
Yeah, it's basically a way for us to use our joints to mobilize the nerves, so to create nerve motion without allowing muscle stiffness or joint stiffness to get in the way. So we're kind of specifically targeting the nerves and how they slide as you move your body. So upper extremity nerve flossing often involves like wrist and hand motions, like so. If it's an older nerve, then coming in behind. Terry's doing a really nice interpretive dance routine there, but it can be done for the lower extremities as well as the upper extremities.
I had some problems with my fingers, and so I had to do this crazy exercise. You were just doing it with your and then you moved. Yeah, that was it.
Yeah, so it's a common sort of part of PT. I quickly see Janet there, hand and finger numbness.
Well, actually, we have Diana next.
Okay.
Go ahead, Diana.
Hi. When I do the sit toe raise, my toes cramp. should I work through this or?
We're laughing just not because it's funny that you're cramping, but it's a really common sort of initial thing. So as the muscles get fatigued, one of the things that happens is cramping occurs. So that's a sign that you've probably used a lot of the muscles of the toes to help with the motion. And it could be also that you're getting a circulatory response. So as blood flow increases through there, what can happen is that the muscles can sort of cramp in response. So stretching can help immediately sort of with the cramping. Pat and I have talked in the clinic about sort of how cramping relates to nerve function, but also things like hydration and sleeping and stuff like that. So long way of saying cramping is okay, and it's sort of a normal expected response, and it's something that should improve as the endurance and the strength of the muscles get better.
Okay. It's next is Janet about finger and hand numbness. Do you
Yeah,
have-
so just like we do sensory stuff for the feet on different surfaces, we can do the same thing in the clinic with the hands. So hand and finger numbness is a big category, lots of different reasons for it. So sort of what Terry was talking about, if the numbness and tingling is related to a specific nerve, a peripheral nerve, then nerve flossing can be helpful at getting the nerve moving so that numbness and tingling improves. If it's more of a circulatory thing, now we're talking about the aerobic component and really taxing the autonomic nervous system. And if it's more of an issue of the brain interpreting signals, then using different surfaces, gripping, tasks, that kind of stuff. Yes, hand and finger numbness can be addressed with PT.
Okay. Steve Klitzman, you have a question?
Yeah, I came in late. I'm sorry about that. So you may have discussed this, but I've had peripheral neuropathy for 13 years, and I've periodically done physical therapy. I frankly have never found it terribly helpful. I've never found a therapist who really understands peripheral neuropathy and almost specializes in it. Do you guys specialize in it, or it's just a condition that is common and that you apply the usual balance and strengthening and muscle movement and all of that? But I've never felt confident that the PT people I've used really knew what they were doing. Maybe that's not fair, but it's never made much difference for me. And I don't know what other people think. I have numbness in my feet. I don't have any pain, but I find the therapy, that the best thing I find is water aerobics. I find immediately relief. It's not weight bearing. I've been swimming 3 times a week, and I've done that on my own. But actually going to a therapist and moving my bodies and doing balancing exercises, it doesn't seem to amount to very much. Am I wrong?
I would like to interrupt and answer before Jaime and Collin. One of the reasons that I specifically asked them to come today is because I have been to probably, I don't know, 6 or 8 physical therapy groups over shoulder issues, back issues before my surgery. And I felt that the difference here is that they were very attuned to my particular problem. It wasn't this packaged program of mobility training. It was very specifically that Pat can't stay balanced without falling. It's almost embarrassing sometimes because Collin stands there to model it and I try to do it and I immediately step over the line or off balance or whatever. But I'm encouraged because I leave there hot, I leave there tired, I leave there energized. I feel like I've accomplished something, and it's been different for me than going to other physical therapists. But go ahead, Jaime and Collin. Do you have a response to Steve?
I do. I mean, PT doesn't always work. Peripheral neuropathy is a very, what we call heterogeneous condition. Depending on the cause of it, the chronicity of it, what sort of is contributing to it. PT might not be the thing that gives you the increased quality of life, the increased balance, all the things that you're looking for. What a good PT should be able to do is work with you and be on the same page as you as far as the efficacy. And if a standard routine isn't working, that PT should be able to change what they're doing, change the strategy to really figure out and find out what it works for you. It sounds like you've gotten to a point where you have a pretty good strategy for managing your pain, which sounds like some sort of aquatic therapy, which is great. Just because we're here saying that PT can be helpful for a lot of people with peripheral neuropathy doesn't mean it can be helpful for you. So if you've already been through it and you feel like you've exhausted
the underlying problem is that the neuropathy comes from the degeneration of the nerves. The nerves aren't working anymore.
Right.
So no therapy can really restore your nerves, can it? I don't think so.
Correct. I mean, if we're out here restoring the nerves and feet, then we would be billionaires.
I know some people claim it doesn't. So that's where I guess I come in with skepticism. You can't restore my nerves. What's the point? But maybe I haven't been fair to it. I've done it for 6 months at a time, a year at a time, and still I started doing the water aerobics. I just didn't feel any benefit coming from it.
Yeah, well, and that's fine. Again, so part of what we alluded to in the presentation was for those people who aren't seeing the improvement, a PT should be talking to you about compensation strategies. So what sort of assistive devices, adaptive devices, how can you function the best that you can, given the fact that this might not change at all? And while that's not a specific to your body improvement, it can relate to an improvement in your quality of life and your function.
Are you located in Virginia only, or are you in Maryland and DC also?
So we, in this area here, it is only Northern Virginia. We are branching out. PT Solutions is under one canopy and we are around 18 states. In this area, you can find us at Alexandria, Potomac Yards, and right here in Falls Church. And then we are also as far out as Herndon and Lake Ridge. So unfortunately, we have not hit the market in Maryland and DC just yet. We're hoping to make those expansions as we continue to grow.
Thank you.
I also wanted to mention that on their brochures and forms, they emphasize that. Did you know that you can see us without a prescription from your physician? Direct access laws allow patients to receive physical therapy services without requiring a physician's referral. And I think that's really important for people to understand that you don't have to go to your general practitioner or your internist to get a referral. You can go to them and have the assessment done and see if they have suggestions for me, it is functionality. I'm not looking to relieve really the burning. I want to be able to make sure that if I fall, I don't injure myself or I can get up again, that kind of information. We have one question already in the chat about, are there research studies about peripheral neuropathy and strength and balance training that we can look up or refer to? You might not know that off the cuff, but we can certainly post that on the website if you have suggestions. You mentioned one at the beginning,
yes,
the 2-year study, which I found helpful. But I think everyone looks for research for the cure, but they don't look for research for what do you do in the meantime.
Yeah, before going into the research aspect, I will say for the direct access component, although yes, there are the aspect where you can receive physical therapy for 60 days, do bear in mind it is variable on your insurance. Now, Medicare is one of the insurances that require a referral from your physician in order to initiate PT. Now, don't let that discourage you. As PT Solutions, we want to give back to our communities. And what we can offer is a 30-minute free consultation to anybody without utilizing any of your insurance. It's for us to just do a quick screen, evaluate you, and tell you whether or not PT is appropriate for you. So that's something that we do as complementary services to our community as well.
And now on the research aspect, I'm seeing a lot of comments in the chat, which is great. I will absolutely provide the sort of the link or the reference to the study that I talked about in the PowerPoint, and also I'll send out a couple of other studies as well that have looked at peripheral neuropathy and physical therapy. So I will make sure that that Pat has those resources that we've made reference to, and a couple of other sort of
excellent.
studies that we've seen. I see a question on creatine powder. Muscle strengthener, no. So creatine is one of these sort of workout supplements. What it basically does is it increases the available immediate energy in your muscle. So it helps to create something called ATP. That alone is not going to produce any changes. It just makes you more able to, I guess, tap into those stores. I would say that for the rehab setting, creatine has little use or little function. Most of the studies on creatine, at least talking about peripheral neuropathy, we're talking more about elite athletes and how their bodies utilize creatine. I do not know if there's any research or literature as it relates to creatine and specifically peripheral neuropathy, but my guess is I wouldn't bother with it. But what I'll do is after we're done here, I'll take a quick little look to see if anything exists. And if it does, I'll include that along with the other references that I'm going to forward.
I promised Jaime and Collin only 1 hour of their time, and we do have other agenda items to address, but we will have this one last question that was posted in the chat. Have you done any work with arthrofibrosis?
Yeah. Go ahead.
I mean, yes, we have really everything. We're looking into fibrotic changes, arthritic changes into the body itself. We have a general knowledge, and then again, Collin and I both are board certified orthopedic certified specialists. So we went into more of the depth to study and learn how we can help each individual and cater plan of care specifically for each person.
Arthrofibrosis, I would say we've seen mostly in the knee as it relates to post-operative procedures, but also insidious onset. So some of these more stiffening changes, it can be systemic in nature. So someone who has some sort of systemic disease that can contribute to joint stiffening and fibrotic changes, but also post-operatively, if there's excessive scar tissue for whatever reason, a joint can be fibrotic, and that should be up the wheelhouse of just about any PT. Especially one who again has spent a little bit more time looking into the orthopedic literature like we have. My PT told me to brush my teeth on one leg. Great, if you can do that safely. Great way to incorporate balance into your routine. And any creative ideas. I think a group like this, a support network, is so valuable. And just comments like that. Here's what I've done in PT that may be helpful. Sharing ideas, sharing strategies, sharing support stories, sharing maybe not support or like not success stories like Steve has had. I think it's such an important thing to have a group like this available and to be able to network and share ideas and share stories like this. So it was really an honor for us to be able to sit down and talk with you guys. Again, we apologize for any possible hearing or connectivity issues. Hopefully we've addressed or cleaned up any questions here in the post. We have a couple things that we'll do after this, including sending some of those resources. I'll take that quick look into creatine. What we're also going to do is we're going to give Pat our contact information. If any of you have more specific questions, you are more than welcome to use us as resources. Feel free to reach out over email. Happy to answer any more questions that we weren't able to get to today. But hopefully this was worth your time. It certainly was worth ours. It's really nice to be able to speak again with all of you, and best of luck for the rest of the day. Thanks for having us. And Pat, if there's anything else you need from us.
Excellent. Thank you so much. You met all of my expectations and beyond. I'm holding up their business cards. These will be posted. The contact information actually could be sent out to everyone, but it will also be posted on the website along with, as I understand it, the presentation, which I think would be an invaluable cross-reference to go back and look at and maybe get some answers to questions that you didn't get to ask. But we so appreciate your time. We know you took away from your own families, so we appreciate your coming on a Saturday. And round of applause. Thank you very much for an insightful and helpful presentation. And you don't have to listen to the rest of our housekeeping.
All right, thank you again.
Thank you. Bye-bye.
Thank you all.
We're going to move now to remember, the chat can be saved. So these questions can be saved at the end to your own computer if you want to go back to them. And Rodney does an amazing job of capturing what happens at our meetings, and this was recorded. So you have many different ways of looking back on what happened today and issues that maybe were raised in your mind. And I think it's great that these two physical therapists are willing to address our concerns and go even beyond just today's presentation. Terry, we're ready. We're very proud to announce, and thank you, Lou Mazaway, as well, that Terry's personal story was recently published on the Foundation for Peripheral Neuropathy's website. They asked for personal stories so that people can learn, just as Collin and Jaime said, from the sharing of information. And Terry's going to just briefly tell us about her story and how she chose to write it. Go ahead, Terry.
Oh, so when I first got peripheral neuropathy, I started Googling around and I found the Foundation for Peripheral Neuropathy website. And there I found the contact for this group. And I contacted Steve. And Steve introduced me to the group, and I joined during the well, we're still in the pandemic, unfortunately. Joined during that and met everybody on Zoom, and actually met Pat, who actually doesn't live too far from me, in person. And it was just great to, know people who had this disorder, and you guys are a great support to me. So that was the success story for me, having all of you to support me. So I wrote that up for the foundation, and it got published this July. So I think it's still on their website if anyone would like to read it.
Right. And Terry has also been asked by Nancy Froman, the Director of Program Management for the Foundation, to be on a focus group panel. And maybe others of you would like to be on a focus group. And if so, we can certainly connect you with Lou. I don't know how they choose their, Lou, if you want to address the focus groups, if you know.
Jane St. John.
Yeah, I don't really.
Join the meeting.
Thanks, Pop. I don't really know how, Nancy and really is in charge of that. So.
All right, we'll publish Nancy's contact information, or I'll check with her if she would like other people involved. But we're very proud of Terry taking the initiative to publish not only her own story, but how a local support group can help. And we hope to connect and continue to develop that in a network. You'll hear more about that later. Our next agenda item is from a treasurer's report from Rebecca, who is going to talk to us just for a second about our funding situation. Rebecca?
Yeah, hi Pat, hi everybody. I have not received any deposits since 7/14/2021, so we still have $1,341 in the bank.
Okay, Mike Foxworth has just shared with Rebecca his projected budget, I think for 2022 or the upcoming year. We will, again, always be asking for your considered financial support. I know Steve had some issues last month with Cheddar Up, the online donation system that we have. But remember, you can always go old fashioned, old school and send a check to Rebecca. Her address is on the website, or you can talk directly to Judd if you would like to make a donation. Thankfully, we aren't charged for most of our presentations, but we do have operating expenses like the website, like the Facebook page, etc. So,
and if I could just say something, none of us are paid for anything. So if you want to keep having these meetings, we're going to have to support the Zooms and the Otter thingies and the Cheddar Ups and all that. So if you can send $5, that'll help. 5, 10, 15, 1,500, that would be great. But anyway, please support us.
And thank you for that little infomercial there, because it is true that these expenses have often been paid by just individual members and haven't even asked for reimbursement as we've moved forward, but we can't continue to operate that way. And when we met physically and we could pass the hat, we were covering our expenses fine. But people have good intentions and then they close the Zoom meeting and then they forget to do it. So this is just, again, a little reminder that your help would be appreciated in that way. we are going to go now. Happily, we have some time for open discussion, and we're going to begin by asking anyone who is new to the group, maybe only has been here today or one or two times, if they'd like to raise their hand and introduce themselves and tell a little bit about your personal journey. And if I don't see your hand, Mike or Terry, will you tell me, please?
Sure.
And please unmute.
I don't know if Nora is still here. She's on her phone from Ireland. Nora, are you here? Nora.
Nora?
And Jerry Piazza also.
Yes, we see that. Is Nora here, please? Okay. No, all right. Janet is raising her hand, and then Jerry. Janet, please introduce yourself.
Yes, my name is Janet Franco, and I had attended meetings of your group previous years, but I've gotten away from it. And I have peripheral neuropathy on all the fingers of my hands and also on my feet. So I haven't been able to find anything to provide relief. I had carpal tunnel surgery, so I don't have the pain in my hands, but the numbness has never gone away. So I don't know if anyone has any suggestions, or I'm also undergoing chemotherapy for cancer, so that's made it even worse.
Of course.
So, you know, I'm looking for some kind of, you know, improvement if possible.
Right. I think that it's a constant topic of discussion as everyone tries to share information about what has worked for them and what hasn't. And people have gone from the extreme of putting their feet in an ice bath before they go to bed to somebody else saying, no, 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 it has to be hot. So it is what Jaime and Collin were saying. It is so individualized that you can't maybe perhaps say a general response, but does anyone have a response to Janet about her tingling, especially with chemo-induced?
Numbness, yeah, mostly numbness.
Have you consulted with your oncologist about the neurological effects of the chemo? Because there have been some studies. There have been some studies that have identified certain chemicals as better or worse for chemo, and I know people at Johns Hopkins have been studying that also. So are you talking to him?
Oh yes, during each treatment, they give me ice on my hands and my feet to reduce the amount of damage, but it helps a little bit, not a lot.
But you had the neuropathy before the chemo, right?
Correct, because I also have diabetes.
Oh, okay. So do you have a neurologist you're working with as well as an oncologist?
Well, yes, but there's not really anything they can suggest.
Right.
And I did submit my name for some kind of study that your group sent out.
Oh,
and I said I would be happy to participate.
Lynn Santor.
Yeah, I just sent that out a day ago, yesterday. We had a speaker in March or April, I think, who's the CEO of a company called Win Santor for Winnipeg, San Francisco, Toronto, and they're developing drugs to deal with neuropathy. And so they have a new study for people with diabetic neuropathy, and they're looking for participants, and it would be a free study. So I sent that to the mail list, and you probably got that. And so I would follow up on that. Maybe you can get involved with that study.
Possibly, but it's in Roanoke, so that would be a problem for me to go there.
Say again?
They said the study's in Roanoke. You have to drive to Roanoke.
Oh, really? You'd already told you that you can't do it by Zoom or email?
Well, when I submitted it, that's what I saw on the web, on the information.
Well,
I'll wait to hear from them, but I was encouraged that there was something going on.
Yeah, that's a little strange because they're in California, and I don't know why they would pick Roanoke as a site to go to. So
I know it was odd to me, but
yeah.
I think their study is, though, specifically on people who had the PN develop after their chemotherapy and their diabetes. And basically what I've read is that the best way to get rid of the PN is to get rid of your cancer, finish with your chemotherapy. And I don't know if you can get rid of diabetes, but at least reduce it to a minimum. And this is probably the best way to reduce the PN as well.
Well, actually, my peripheral neuropathy was, I had it before I had treatment, but the treatment makes it worse. And then after 2 or 3 weeks, it gets back to the original. So it never goes away, but the
It
chemo doesn't help.
intensifies. Yes, I see. It's cyclical, it seems, dependent on your stage of treatment, your cancer treatment, whatever. There are many forums. There are exchanges on Facebook. Do you do Facebook, Janet?
I do, but I haven't searched out for peripheral neuropathy, but I don't do Facebook a lot. I do it for my community, but I think it's like what Steve said, there's not really going to be a permanent solution because it's nerve damage. That's what I've discovered, but
I think that's what we're understanding. But what I'm talking about as far as the Facebook forums is there is a lot of information exchanged, from supplements to prescription drugs to exercise to hot and cold baths, as I said. This group actually has a Facebook page called On Your Feet. And we've just had 12 new members join, so we're very happy to hear that. If any of you have not joined and are on Facebook, you might want to look at that. There's also another one called PN Success Stories, which is administered by a gentleman named Michael Wright. We can put these in the chat so that, and they're definitely on our website. I can't say enough how you need to look at the website. Judd and Mike spend an amazing amount of time updating information on it about studies and articles that people like Bruce have pointed us to. And now we'll have Jaime and Collin's a reference to the study that they referenced and others that he's willing to look up. It's evolving, it's constant. I think the message is that you need to stay, not you personally, one needs to stay in touch with these information sources because it literally changes daily. So thank you, Janet, for your questions and welcome. Jerry Piazza, you are next. Welcome.
I am so delighted that this group exists because when the neurologist gave me the diagnosis, that's all he gave me. He just gave me the words. And I have no idea what's going on with my body. And it was so helpful to find the foundation website and to read patient stories and to read the, all the information there, and then to find this group from that website. And the presentation today was exactly what I needed to hear because I want to do whatever I possibly can to retain what function I have for as long as I can. That's just my personality. So I'm still on a journey with the neurologist for trying to see if there's a reason for my condition. And so that's been a lot of fun with all the painful tests and so forth I've been going through. But I'm really, really, really delighted that this group exists. I'm really, really impressed. And what I do for a living is writing about research, biomedical research. I work for the National Institute on Aging, which is kind of ironic because I never really dreamed that I would be on this side of the research. But that's what NIH does, is we fund the clinical studies and so forth. And my agency is focused on providing exercise plans for older adults to prevent falling and everything. And I didn't imagine that at age 55, I would be thinking about all of these things for myself, as opposed to providing that information to others. So in the future, as I can, I will be helping to provide information to this group. I'm still learning myself, But that's what I do for a living. I do science writing and health communication. So as I learn about peripheral neuropathy, I'll be sharing that with this group.
Well,
How
thank
long
you
have you
very
had
Can
it?
I interject for a second? In the past, we've tried to make a contact at NIH in the division that focuses on neurological disease. I forget the name of it. It has a couple of
Yeah,
N's in it.
I just call it NINDS, NINDS,
Right.
the National
So
Institute of Neurological Diseases and Stroke.
we've had names thrown at us, but we've never been able to really connect with like a public information officer or a leading doctor or someone who could come to our support group, because we're the only support group, frankly, in DC, Maryland, or Virginia right now. I mean, it's sort of ridiculous. There should be many more. And we've been in existence since 1998. But I led the group before Pat for quite a while, for 10 years or so. And periodically we would reach out to NIH and we never got anywhere. So do you have contacts or a fellow officer in that division of NIH who could see if they'd be receptive to meeting with us?
So for what I do, Monday through Friday, I'm a public information officer just for a different agency. And so, yes, we do work closely with the Neurological Institute, those PIOs for my work. I'm just, at this moment, I don't know who is involved with peripheral neuropathy. I don't know who does the research, but as I said, as I learn about that, then I can make that connection.
We had Dr. Kornblath once from Hopkins, David Kornblath, who's a leading neurologist there with Dr. Hoke. He's Lou Mazoe's doctor. And this was 8 years ago in October of 2013. And he told us at that time that it was a real struggle to get NIH to fund research on peripheral neuropathy. It was like a flatline amount, like $100 million for several years in a row. And he wasn't too optimistic that it was going to change. And he urged us to contact the NIH, but we never really got our act together to do that. But just to get some contact going and see what's actually happening, see if it's changing. We were involved, for your information, and I'll shut up. Last year, Congress amended this Defense Department provision allowing peripheral neuropathy to receive research funding through the Defense Department. I forget what it's called exactly, peer review.
much.
And they list diseases that can be funded. And for at least 3 or 4 years, we were trying to get peripheral neuropathy funded or on the list to get funding and didn't succeed. We finally succeeded last year. So is going to be a potential source for research. So we really should get some kind of an update about what's going on and what can we do to help, move the needle on this, because it's frankly been pretty static for the last several years. And if it's still $100 million, that's not very much. And in a budget that must be $5 to $10 billion, I'm sure.
Jerry, I would like to welcome you and say it's unfortunate that you are brought to us with the disease, but we are actually happy to welcome you because I see the connection will be made and we can be mutually helpful, I hope. And so
Thank you, Pat.
We will
tell us about you. I don't know her. What's your problem? What do you have so I can understand your situation?
Well, my legs and my hands. I have neuropathy. They're numb. It's different every day.
How long have you had it?
So, excuse me, I just got the diagnosis, but I've been on this journey to get a diagnosis for 2 years. And I think it started slowly a long time ago. And for some reason, it just started progress more quickly since last summer. I don't know why.
Well, I think one of the issues also for all of us is finding the right medical provider, practitioner, advisor, neurologist, however you want to name the person. We do have something on our website called a resource directory.
I saw that.
We are trying to share information. And again, to all of the members here who are faithfully attending our monthly meetings, please equally faithfully update that resource directory. We took the password requirement away to make it easier. It should not be difficult for you to be able to add a provider, an assistive technology person that you found that was particularly helpful in getting your automobile controls, whatever. It can even just be the medications and supplements. So please look at the resource directory. It's only as good as the people who add and keep it up to date. Do we have other questions? Bruce, go ahead.
Yeah, I would just say to all the newcomers, our motto is, you are not alone. We want to support you and we welcome you with open arms. And to Steve, I wanted to ask, have we talked to Lindsay Colbert at the foundation about their possible contacts with NIH and NINS?
No, we haven't. I mean, that's a good suggestion. We could follow
They
up
have,
with them.
they have good contacts. They even have a lobbyist and all that.
Well, who would have a lobbyist? The foundation?
Yes.
They do, but it's more important.
Well, Lou
what
knows
they
more
know.
about that. There is no
Lou is
lobbyist.
raising his hand to respond. Go ahead, Lou.
Yeah, we were just talking about, we've been talking with Lindsay about the trying to do more with NIH, and we were talking with our lobby. We do have a lobbyist, Mark Beef. He's been helping. He's the guy that got us into the
DOD
Defense Department program, right? And he says, he's offering next year maybe to spend some time trying to connect Lindsay with some of the people at NIH. I mean, it's you got to really know the ropes, and he, if anybody does, he does. But it's very challenging to try to get, any kind of.
Can't you just send a note or a call to Francis Collins and ask her this question? Really, it's not that hard.
Yeah, I mean, well, he spoke at the, he's kind of the face of the thing, but he's not the guy that's going to get it done. Bruce.
No, but he can be first. That place.
Yeah, no, we're conscious of it. It's a challenge. It's a challenge now the way it was in 2013 when Tornblatt first talked about it to the group.
Okay, Mike Foxworth, your hand is up. Mike?
No, he's just dead.
Okay, he's not available at the moment. Anybody else who would like to introduce themselves or talk a little bit about questions or sharing they would like to do? Anyone? We haven't heard from Diane or Mohammed today. Bob Quick.
I want to say something, if you guys don't mind.
Please say your name to everyone.
It's Terry.
I know, but other people don't know that.
Sorry, Terry Orlando. I saw on the Peripheral Neuropathy success stories page that a lot of people are doing this Synetics, and I searched for it. It's like a TENS unit that's like it's like electrical stimulation that's like more intense than regular TENS. So I looked up in Northern Virginia, and there's this place in Burke that does it. It's like new. So I'm just going to go for a consult next Friday to see what they say to me. The consult's free, but I'm just very curious. It's like a pain management TENS unit, Synexted. Has anyone tried that or seen that?
Can you put it in the chat, please, when you're finished talking, so that people at least can look it up if they're interested? Anyone have any familiarity? Helene, do you know something about Connect?
No, I'm sorry. I just actually wanted to thank you for arranging today's presentation. It was really a wonderful presentation, and thank you for the connection.
Thank you for saying that. And they did not do it to inspire business, I guarantee you. They authentically responded as soon as I started talking about it, because I do believe that they've helped me tremendously. And what I've liked the most, as I said, I've gone to other physical therapists. The thing I've liked the most is they tweak it every session is changed. I don't do the same thing. They know that the last time I had trouble with this, so they modify it, whatever. So I'm not plugging them as a commercial, but I do think that they have been very helpful to me. All right.
Bob
Mike-
Quick had
Yeah.
a thing too.
Bob Quick, hello. Yes.
Hi, this is my second time in a meeting here. And
Good.
it's the
Thank you for returning.
first time I've been able to, I'll keep this short. First time I've been able to come to this organization. Although I've known Steve since the final disastrous collapse of the previous peripheral neuropathy group. Remember, Steve?
Oh, the National Association?
Yeah.
That's when you and I met at their convention, their one and only convention.
Yeah,
in
right.
DC.
Well, since Steve has been the real leader.
Well, I was just taking over the group in Virginia, and the Neuropathy Association had an annual meeting at the Hilton Hotel in DC, and that's where I met you. And then, are you still leading the group at the?
No, that's the point to make. I have just stopped being the leader of the support group, which I helped found 3 years ago. This is a peripheral support group in the
in Riverdale,
Riderwood.
Riderwood.
It differs from your organization considerably in a couple of respects. One, you have always been an open organization with a wide span of looking at it, the group of ages, right? Aging all the time. The Riderwood is a retirement community, part of the chain of sponsored through our Erickson Senior Living. And Erickson Senior Living medical section has a full-blown physical therapy clinic at Riderwood. And I'm sure if I had a chance to, the people you had on today, but most of
But your group is restricted to residents of Riderwood.
Yeah.
Right.
Anyway, I'm planning now to join your group.
Oh, good.
I no longer have to do all the work for the one in our organization. That's about it. My background is that I have been a neurological problem to myself and to a bunch of physicians since about 1950, 1954. I entered this group through myasthenia. I had myasthenia gravis, fortunately ocular, which affected my eyes only, but that problem, I won't go through the whole strain of it, led into a diagnosis of ocular myasthenia gravis. And I was very fortunate in being referred to a physician, a member of the neurology group, joint practice, which is all through this area, who led me through the myasthenia problems, and then very promptly found all the symptoms of myasthenia, of peripheral neuropathy, which I've had ever since in one form or another. I'll probably be around your group for a while now.
Excellent. Well, welcome. Bob, could I ask you, is your group continuing? You said you've stopped being the leader. Is the group still?
Yes. Oh, yes. I am delighted that the role I've played has been taken by a retired physician.
Okay.
Who obviously is a resident at Riderwood and who has been a neuropathy patient for over 20 years. He's fairly seriously affected. So he has, and in the years I was running the program, he was one of the very most important people we had on panels of discussion of the symptoms, which allowed for very good direct cooperation between patients and people with some expertise.
Can you send us his name and email address? Or if I send you an email address, maybe you can send us.
Well, Steve, how active are you in the Washington group now?
Well, I'm still pretty active. I'm the program coordinator, so I help select.
Yeah, well, that
speakers
would
for
be
the
very
group.
important. Yeah, I'll do that because I think you should at least get acquainted with.
Right. I remember him. If there's a guy I remember, I've spoken to your group 2 or 3 times over the years,
right.
and as I remember, he would often sit to the left of that long seminar table, and he identified himself as a physician, and he seemed very knowledgeable. I don't remember his name though. What is his name again?
This is Henry. Oh God.
Well, Henry. Okay,
I'm having trouble with
names. That's a
That's
start.
okay, Bob. We can reconnect, Bob. I
We'll
just have one-
reconnect. That's good.
I'll email you, Steve.
Okay, we'll be in touch. Okay,
That's
good.
all.
Bob, is this located in Maryland, I presume?
Yeah, it's in
Oh,
Maryland.
yes, Silver Spring.
Silver
Silver
Spring.
Spring.
And is it only open to people who reside at Riders Wood?
Yes, there's one other. It's a direct sponsored organization,
right?
Which has been a tremendous benefit to us. The medical services have been absolutely marvelous, getting us through what we're just getting out of, unless we're getting back into it again.
All right. We will get in touch with you, Bob, to get Dr. Henry's full name and email contact. We have just a few minutes before we have our wrap up. Is there anyone that we haven't heard from who would like to speak? Mary Beth, Ann?
I could say something. Yeah.
Mike Foxworth,
Right.
go ahead, please.
Yeah, I just wanted to make the point that physical therapy and exercise are designed to slow the process. They're designed to tell your body that this is something I want to preserve. The body is going to, it's a use it or lose it kind of situation. If you don't use your muscles because you've lost your balance and you think, oh, I can't move, then your body is going to take that as an indication that you don't want to move those muscles and you don't care about those muscles any longer. And it's just going to speed up the process of destruction. So what you're doing with physical therapy and exercise is you're trying to slow the process down. Whether you can slow it down to the point where it stops degrading, probably doubtful, but every day you live without falling down is another day to enjoy something else. So it's really nice to be able to slow things down. And so the more exercise you do, the better you're going to be able to slow this down. But it won't reverse it. Once the nerve has gotten to the point where it no longer functions at all, the body's not going to keep trying to repair it. And in particular, the nerves that drive your muscles, once they're dead, then that muscle has no way of being exercised any longer, and that muscle will atrophy. That muscle will basically be reabsorbed into your body. More than that, the most important kind of exercise you need to do is exercises that really stress the muscle, push it to its limit. So stepping up, walking upstairs, even if you have to hold on to the handrails and pull yourself up by your arms, though that process of actually pushing your body as hard as you can, that exercises the muscles, what they're called the fast twitch muscles, the muscles that tend to be the ones that die off the first. And so it's not only exercise, it's also pushing yourself really hard to the limit. That's really important. And one of the things that physical therapists will do is try to get you to push it just a little bit harder.
Absolutely. I found that out very early on when he asked me to do a balance exercise, and I said, well, I could have done this better at the beginning. My legs are shaking. They're so tired. He said, that's the point. That's why I'm asking you to do it now, to push it just a little bit more. So
Also, one other thing, I have recently reacquired something called a balance board. I have a Wii game system, and it has what's called a balance board. You stand on it and it can tell you whether you're balanced or not. I have read of groups and in situations where people actually use these. They take them to PN meetings that people stand on them in order to evaluate how good their balance is. That's something we might want to consider doing once we start meeting again in person. It's a little hard to do that over Zoom, but
yes, I was actually pleased with the exercises today that they demonstrated, because I wasn't sure if it would work over Zoom, and I think it did. And they are going to be as given to us as handouts. So we will be posting on the website again, a commercial for the website. If you're looking for information, please make sure that you check it out. Give us a few days to get the information from them and get it posted, etc. But look for it. We now need to move on. Oh, Mohammed, go ahead. You haven't had
Really excellent
turn
presentation.
today.
Congratulations. Can you hear me?
Yes.
Yeah.
People don't hear me. But anyway, I have Parkinson's. Two items. One is that I'm reading the Financial Times covering the Tokyo Olympics, and a big mention about the footwear makers benefiting from the runners. So I'm going to write to Nike, to New Balance, to a Swiss company called O, and a couple of other things. What have you got for footwear for with neuropathy, peripheral neuropathy? I'm sure they have it. I'm told that the Germans are doing a very close cooperation between the medical profession and the footwear people. And so one of us is a German speaker. Perhaps you can catch up on his German and find out from the German companies like is it New Balance or is it? I can't remember the German companies. Anyway, the point is that I'm going to contact these companies and ask for information and also some advice. Secondly, my neuropathy, my podiatrist, my podi, I have this flat feet, and so because of my neuropathy, and they sent me to a company for braces. And my ankles are squashed, and they charged $2,500, $2,600. Anyway, we got a call yesterday, and they're saying, all right, the insurance company 100%, so we're going to start making the most in 2 or 3 weeks' time. If anybody has any information on braces for that kind of foot condition, I'd be very grateful. Whether they inform Keith and go.
What is the treatment? What do they do? They raise your feet? What do they do?
I don't know. I'm going to ask my wife. Sally, what are these braces do?
I'm sorry, what?
These braces, what do they do?
To help support your ankles so they don't pronate.
So it's a brace. It's a brace.
Super pronating,
right?
And they support the ankle.
Well, that leads into our next speaker, doesn't it, Terry? Is Joe Terpenning in October or November? I think he's October, isn't he?
Joanne is going to speak to that. Go ahead, Joanne. You have to unmute. Unmute, Joanne.
Okay, I'm unmuted. All right. Well, I'm really excited that Joe Terpenning is coming in October 2nd for that meeting. And he is from Infinite Technologies. And while I haven't worked with Joe, I guess I saw him once for an evaluation, but I've worked with their office in Loudon. And I've had braces, and here they are for, here's one. I wear them on both legs for the past 3 years. If I didn't have these braces, I would be in much worse condition. I can't say enough about how much they've helped me. And I wear them all the time. Also, they are primarily, I think, designed for people with drop foot, which I have. And so with drop foot, you're always in danger of tripping. And this stops that danger. But it also, the way these are made, it braces my calf from my knee down and helps me a lot. So anyway, Joe Terpenning is the head of Infinite Technologies, and we'll be talking about braces and possibly other devices that they're developing. I don't know. Primarily, I believe it will be the braces. And also, to move on to November, in November, I'm also excited because I've been, I gave up on my neurologist in Northern Virginia and made a contact at Hopkins, primarily following up on the article that was in the Post. And I don't remember the person's name who wrote that, but
The Mobleys,
the Mobleys, yes.
The
yes.
Mobleys,
Anyway,
right.
they gave me a phone number, and I have been going for the past 2 years to Hopkins, working with a neurologist. Her name is Charlotte Sumner, and she's primarily interested in something called CMT, which is a type of peripheral neuropathy that is genetic. But they're also very interested in other aspects of peripheral neuropathy. And as my husband and I discovered, one of the best aspects, or one of the nice aspects of going to Hopkins, is that instead of being greeted by my neurologist with, it's idiopathic and see you next year, they're truly interested in looking at my symptoms and whether I'm progressing and so forth. And Dr. Sumner and Dr. McCrae, and it might be one or both of them, will be talking to us in November about their work at Hopkins. And
Joanne, can you say again what their primary interest is? What did you say? What aspect of peripheral neuropathy?
It's a genetic syndrome called CMT, or Charcot-Marie-Tooth syndrome.
Yes.
And you can look that up on the internet. There's a lot of information.
Yes.
And the latest thing is that they've actually gotten saliva samples from me and from my 2 sisters, one of whom is also very affected. And so I'm hoping that there'll be some interesting information that will come out of that genetic study.
That's
So
that's one of the exciting things about going to Hopkins. They also did a genetic test for me, but it didn't show anything because both my mother and sister have peripheral neuropathy, and we thought maybe there was a genetic component. Mohammed, do you have a question?
That was very, very interesting to hear that, because Infamous Technologies is the guys who charged me $2,700. I'm delighted to hear that they're coming, and I'm delighted to get her email.
Yeah, on October 2nd.
October 2nd. Also, Mohammed, my braces were covered by Medicare. Or
Mine
Medicaid,
too.
whatever.
Medicare.
Yeah,
You're not on
Medicare.
Medicaid.
And Mohammed, are you saying that your 2,600 would be covered by
It
insurance?
is actually yesterday, we heard yesterday that they are covering it.
Okay.
100%.
Excellent.
Can I add something? I'm Joanne's caretaker, I guess. Caregiver. Yeah, I think
It's a
you're
give and take process.
I just wanted to say that I like to walk, and when she doesn't have her braces on, it's a struggle because she's moving at about 0.01 miles per hour. She puts the braces on, and we can walk together quite nicely and quite comfortably, and she can do miles, and she has done miles, and the braces are really a miracle thing for her particular problem of drop foot. So I'm just trying to make the case that if you don't know about these braces, boy, you may benefit from them.
And I'm curious, who sent you for the braces assessment to begin with? What type of provider?
Okay, my former neurologist in Northern Virginia sent me to a physical therapist with sort of a note about maybe she needs braces. And the physical therapist then put me in touch with Infinite Technology.
Excellent.
But the neurologist did have to sign off, I think, on him.
Do you use a cane or a rollator at all, or a walker, or just the braces?
Mostly just the braces around the house, but if I'm out, I use a hiking pole, usually just one. But
Oh,
that
that's
helps.
good.
Yeah.
Yeah. You know, I should report back to the group. I looked into that Walkerson's thing. I've mentioned it several times. It's a device that's manufactured in Minnesota, and it sends that you put it around your ankles and it sends a signal. It's supposed to send a signal to your brain and helps you balance and walk. And I couldn't get any signals because my neuropathy was too advanced to get it. But if you're a new relatively new patient, and Jerry Piazza may want to look into this. It's called Walkeson, like moccasin, WALKASIN. If your nerves are not as degenerated as mine must be, and you do get these signals, it has the potential to really benefit you, like the braces that Joanne's talking about. It's not cheap. It costs, I think, about $4,000 or $5,000, and it's not clear that it's covered now by Medicare. But I went so far as to bring it to my neurologist at GW, Perry Richardson, and we tried it out, and I could not detect any signal at all, so it wasn't going to benefit me. But for someone who's new to neuropathy, it might benefit you.
All right, excellent. Do we have any other comments or points?
Let me
comment.
Wait, we're gonna do it in order. Bruce was next. Go ahead, please.
Thank you. I have just two final comments. One is I have to recommend that everyone might benefit from reading the new book, Code Breaker, by Walter Isaacson, in which he outlines the entire process by which female scientists, biotechnologists, were able to develop the invention of the human gene editing technique known as CRISPR, and that CRISPR has already resolved some disease problems like sickle cell and Huntington's disease. And it's possible in the future that they can edit human genes that could help us with our PN issues. The other thing is, I hope everybody who is in the core group that I invited will be available on August 19 at 6:30 for one of my social hours, in which we could talk about anything positive except PN and any of its tangential conversations about doctors and pain. Thank you.
Okay, and August 19th is open to everyone.
No,
Excuse me? I'm sorry.
it's only open to the 10 people actually invited.
All right.
I can't deal with hundreds of people.
Well, okay, we're going to clarify then. The third Thursday of the month is the one social hour or happy hour, whatever we're calling it, that is endorsed by this group. So on the third Thursday of the month, an invitation will be sent to everyone to join, to just have some socialization, not focus on the disease aspects. Which brings me to the wrap-ups of the meeting today, which is supposed to be over at 4 o'clock. However, as always, this is open to anyone who would like to stay on and talk, ask each other for more information or questions. Before I do this last bit, go ahead, Mike, your last question, you're in. Mike Foxworth?
I just wanted to say some things about braces. First off, one of the nice things about having the person who's coming next month, I guess it's next month.
October.
It is that if you just go to, I don't know, your doctor, they may give you the basic brace, just a piece of plastic that goes around your foot. It's rigid, and it's probably more dangerous than walking without it, frankly. It's it can, it restricts your ability to move your foot. And anything that restricts your ability to move things is not going to be good for you. So what I did was, at the suggestion of a lady at Hopkins, I bought these things. They're called foot-ups. I got a pair of them for about $100. They do essentially what a brace will do for me, because all I really had to deal with was drop foot. I didn't really have to worry about my legs going side to side, but I had drop foot and I was tripping. And for me, that's all I really needed. So if that's all you really need is you got drop foot and you need to be able to keep your toes up so you don't trip on things, then that's really all you need. I've had these now for about 3 years, and they work really well. I did that. They're held together by Velcro. I found after a while the Velcro kind of gave out, so I bought some Velcro straps to reinforce the Velcro. But what Joe Trivedi is going to talk to you about, one of the things he's going to talk to you about, is more advanced kinds of braces that do allow your feet to flex. And that's very important because you want to keep exercising. You want to keep walking as much as possible. And having some flexibility in your feet is very, very important in order to make that work. Anyway, that's it.
This will be the third time that Joe Treppenning has spoken to us. He spoke twice when we met in Annandale. So this will be his third visit. And so I highly recommend, if you haven't heard him, he's a good speaker and he knows his area very well.
Okay, thank you for that additional information, Mike and Steve. As far as the meeting wrap up, I want to make sure that you know that CJ's holiday is meeting, group is meeting, on Zoom this Monday from 4 to 5:30. He's having it as open discussion. He has decided to stop having speakers and presentations and instead is doing a monthly, I guess, monthly podcast, but he is still having the open discussion meetings. And this August 1 is August 9th, this Monday from 4 to 5:30 Eastern time. And we'll put the information, you just have to do contacting CJ@gmail to get an invitation. Also, we would like to note that there's been a lot of interest about shoes, and CJ had invited an excellent speaker. I can't remember if I think it was from Chicago, I don't know. Anyway, the recording has been taken down for some reason, and a lot of people have referenced it. So we are going to contact CJ to see if we can put the recording on our website. If not, we will be contacting the presenter and ask him if he would be willing to speak to our group, because it was very useful information on different types of shoes and what you need to look for just like Mike's questions about foot drop or tripping or whatever. So that's something to look forward to. Another thing to note is that because of Labor Day weekend, our September date is moved to the second Saturday, September 11th, 9/11, our usual 2 to 4 Eastern time. It will not be Labor Day weekend, but the second week on 9/11. And
Pat, it's Rebecca. I'm not going to be able to make that. So whatever we need to do about the budget, et cetera, you and I will need to handle that in advance.
Okay, that's fine. That's why I try to send out the agenda so that people who are on the spot will know that they're on the spot. We also I've been kicking around the idea of a spin-off on Michael Wright's Success Stories, which is a Facebook page where people, he very specifically designed it for people to share what was good about their life, what their success stories were. And I thought that maybe we could have our own little spin-off and call them something like PN Victories. And I thought I would go ahead and talk about my PN victory is just being able to meet with this group. I had the wonderful and successful experience of back surgery just on April 7th, and the experience of working with the two PT speakers today, Jaime and Collins. I've already said how much they've helped me. But each month, instead of ending on a down note about all of our problems and consequences and issues, maybe we can end on a PN victory. So I was the first. If you have a victory you would like to share for September, please just let me know and we'll be happy to recognize you. Any other comments, questions? My goodness, we're only 5 minutes late. I feel good about that.
Rebecca, can you tell us your address? Because I'll mail you a check. I don't think my donation went through because of that cheddar cheese or whatever it was called thing.
Yeah, it's 10639.
Wait a minute, I'm typing 10639.
Correct. Canterbury Road, Canterberry.
Oh, Canterbury, like Berry. Okay, Canterbury Road.
Yes. See it.
Fairfax Station.
Where? Fairfax Station?
Fairfax Station 22039.
22039. Okay, I'll mail you a check then.
Okay.
Can you post that address? So
I'm trying to right now. Fairfax Station, Virginia, and what is it?
22039.
039. And
I think that's on our website too, isn't it?
it is.
Yeah.
But people ask every month, and
Sure. Okay.
I think while it's fresh in your mind, I'm posting it right now, and we'll put it on for everyone. And
website on your feed, or is there another?
No, it was posted also earlier in the chat, and I'd like to just give it a plug. It's dcpnsupport.org. And I always remember by going right to left. It's an organization to support people with peripheral neuropathy in DC. So you go dcpnsupport.org. Easy.
No space between support and
no.
PN.
Okay, so there's Rebecca, and I'll do this again. dcpnsupport.org.
Let me leave that message on again. Oh, Rebecca's name and address. Okay.
Yeah, it's a Pat.
Yeah.
Am I muted? No, it's HOTOP, HOTOP.
I think automatically corrected. HOTOP. I know that.
Yeah, not
HOTOP. Okay.
Yes.
But 10639 is correct.
Correct, yes.
Yeah. Okay. Excellent.
Pat, this is Kathy Lindstrom. Can I ask, was your back surgery related to your neuropathy?
No, it was not. No.
Okay.
And I was secretly hoping that maybe by some miracle that it was related to the disc and issues in my back, and that I would wake up and feel my feet again. Sadly, it didn't happen.
Oh, I know. I have that same hope.
But I just feel, oh my gosh, I wish I had done the back. I'm not doing a commercial for back surgery, but I wish I had done it sooner, because I just feel completely re-energized and walking and gardening and doing everything that I wasn't able to do before. And I don't know that there isn't a side effect of the physical therapy that I've done for my back, because I do feel that my feet burn less, but I'm not going to say there was a cause and effect.
So was that a herniated disc that you had?
Uh-huh.
Oh, okay.
Yeah.
All right. Well, thank you for that.
Yes.
I'm glad you're doing well.
It was Georgetown, and they were amazing. Very good experience.
Good to hear.
Who was your surgeon at Georgetown?
Oh my gosh, how can I ever Kalantar, Kalantar. Isn't it awful when you can't remember a word that you know as well as your last name? I mean, goodness, Kalantar was amazing. I think the whole experience was so different from what I had experienced with my shoulder. So I'm just over the moon excited. Okay, and on that note, I hope that you enjoyed today and that you learned something. Please share it with someone else. There are so many people who have peripheral neuropathy and either don't know it or don't know even what to do about it. So tell them about our group, tell them about our website, ask them to join us, check out On Your Feet if you do Facebook, and have a wonderful rest of the afternoon. As I said before, all are welcome to stay online on Zoom as long as you need to or want to today. And we will see you on September 11th.
That'll be general discussion, right? No speakers.
That's right, no speaker in September. That's why Joanne didn't announce anyone. We try to have, we did a recent survey of the membership, and the majority of people who responded said they appreciated having every third meeting just be open discussion. And so that's what we are doing in September. And then the October are the technology, the brace technology person, and then November, the neurologist from Hopkins. And December is yet to be determined. We have in the past had a holiday party. We'll see where COVID is at that point and how people feel about getting together or not in person. I will say that Terry Orlando had an interesting suggestion. She was saying if people like the social aspect of getting together, had been willing to host them on her back porch. Maybe 5 or 6 people who are all in the Falls Church, Alexandria area would meet at her house, and we'd all listen to the Zoom, but we would still have some camaraderie and direct contact. And she said, if I have one in Falls Church and Steve hosts one in Maryland and someone else asks to have a group come to DC, then we could have a little bit of both, but we haven't gotten that organized. It's enough to just get something like today to happen. So if you're interested in that, of course, anybody who has ideas that are outside the box, please contact us. We'd be happy to hear new and creative ideas anytime. Okay, on that note, thank you. Yeah.
Thanks a lot. Great job. Thank you.
Thank you.
You're welcome. Judd, did you have something to add?
Oh, I want to say thanks. Great meeting. Yeah.
Okay, good.
I'm going to stay on with you if you don't mind for a minute.
Sure. Anybody, you are welcome to stay as long as you wish. I see a couple of names that I didn't see before. Brian was on that I didn't notice. I hope I didn't miss anyone.
I
And
see
remember,
World Carlson. I hadn't seen him in a while. And who is Nabila? Nabila Hug.
Hello, everyone. I'm Nabila.
Hi, Nabila.
Is this your first
I joined
time?
you guys a couple months ago. Oh gosh, maybe it's been longer than that. It's been a while for one of your sessions. So I'm finally back after a long hiatus.
What is your email address?
ms24nh@gmail.com.
MS what?
24nh.
@gmail.com.
Yes. And I do receive your I did sign up for your email newsletter.
you received an invitation for today, so you are on our list. Good.
Yes.
NS24NH. What are you working now?
No, I'm currently kind of half-heartedly looking.
Okay.
So yeah, I've been helping my mom. She's 81, and that's part of the reason I'm on this call is to understand. She doesn't have
Do you have the neuropathy, or
did.
your mom has the neuropathy?
No, she doesn't, but my dad did before he died.
I see.
So I just want to understand as well as,
Sure. Well, welcome.
in case it happens.
Excellent. Welcome. And we hope you learned something today and will continue to join us.
Yes.
Mohammed? Mohammed?
Yes, thank you very much. Excellent presentation. Well done.
All right. And someone asked when would be the recording of the meeting be available? It'll be a couple of weeks. As I said, we still have to get it from Collin and Jaime, but they have agreed to it. So I'm assuming that it'll be a relatively quick turnaround. I go to see them again on Monday, so I'm sure we'll have a little bit of a postmortem and discuss what went right and what went wrong. So I think it was well worth our time, and I'm very grateful that they came.
Are they the CNP that was on the participant list? I saw someone signed up as CNP. Who is that?
Yes, that's Collin, Phillips, and Jaime Cruz. Phillips and
Okay.
Cruz. Yes.
Okay, cool. What's the name of their practice?
PT Solutions. SOLUTIONS.
PT Solutions.
Pat,
okay.
I've been sitting here doing their exercises because I've been having problems with my ankles. And I was glad Lou was here because I